How's it going, guys? We have a medium difficulty question for Hematology Step 1, Internal Family Medicine 2CK. 59-year-old man. He has long-standing diabetes. Physical exam shows an S3 heart sound, lateralized apex beat, peripheral edema. There's no jugular venous distension. I'll discuss these findings in a moment. Hemoglobin low, 10 grams per deciliter, should be 13 to 17.5, and males, non-menstruating women, 12 to 17.5, menstruating women. MCV low, 75, should be 80 to 100. Iron is low, ferritin's normal. Question wants to know the most likely explanation for the hematologic findings. So looking at the vignette here, S3 heart sounds, a dilated left ventricle, almost always pathologic. Could do a lengthy 40-minute discussion of every detail here, but this is usually just dilated left ventricle pathologically with a lateralized apex beat. So systolic dysfunction, probably some DCM, dilated cardiomyopathy ensuing. There's peripheral edema. So on the surface, at least initially, we could say, oh, well, maybe that's a right heart failure finding where we have left heart failure plus right heart failure equals congestive heart failure. And then I told you there's no JVD, which in real life, it's not mandatory that a patient has every single finding of right heart failure and left heart failure on physical exam. But what I did here is the fact that there's no JVD, but we have peripheral edema in the setting of long-standing diabetes. This was my way of communicating the patient has nephrotic syndrome, diabetic glomerulosclerosis. Diabetes is the most common cause of chronic renal failure, okay? Now, even if you didn't make that connection, it doesn't matter. You can still answer this question, as I'll talk about. So let's look at the labs. So looking at the labs here, you should know right away that if a patient has low iron but a normal ferritin, especially if there's some sort of ongoing medical condition, that's anemia of chronic disease, all right? So an elephant in the room is some of you are going to get emotional and say, but wait, the MCV is low. You can absolutely have microcytic anemia in anemia of chronic disease. In fact, 2CK forms will do that. They'll give you EG, juvenile idiopathic arthritis, juvenile rheumatoid arthritis, MCV 72, anemia of chronic disease, MCV is low, okay? And students like, oh, well, it can't be anemia of chronic disease. It's fucking wrong, okay? It's anemia of chronic disease. So you can have low MCV. Now, another detail is that some of you will say, well, can't ferritin be increasing in anemia of chronic disease? Not really, okay? Ferritin's basically normal. Maybe one question in NBME history, they've given an increased ferritin. But what we have here is normal iron stores. Ferritin is the most sensitive marker of your true iron stores. We have normal iron stores. We're not iron deficient, but we have low iron in the blood. That's due to decreased iron release. So this is anemia of chronic disease, these values. And then you link it to the diabetes here. And then we're going to look at the answers. So let's just hop through. Choice A, cytokine-mediated EPO deficiency, correct answer. Now, if you think this is weird, take it up with Internal Medicine Form 7, I believe it is, maybe Form 8, for the CMS forms, okay? NBME material for 2CK, even though it's very much a Step 1-esque question. Verbatim, the answer they have. So anemia of chronic disease, common causes such as autoimmune disease, sarcoidosis, SLE, IBD, chronic infections, Hep B, Hep C. Renal failure, to my observation, is the highest yield cause of anemia of chronic disease on USMLE. And the mechanism USMLE wants is somehow magically we get cytokine release due to renal failure, namely IL-6, and it can impede EPO secretion. That's one mechanism, okay? And we would give EPO to treat this patient. When we treat anemia of chronic disease, you treat the underlying condition for any etiology, but when the etiology is renal failure, we give EPO. So this is an important basis/mechanism when we have anemia of chronic disease due to renal failure, but in general, simultaneously, we're also going to have IL-6 increasing hepcidin release by the liver. So choice B, wrong fucking answer, okay? So IL-6 is going to cause acute phase protein release by the liver, increased hepcidin release. Hepcidin is going to decrease iron absorption by the gut. It's also going to decrease iron release by macrophages. The latter is the more salient mechanism for most etiologies of anemia of chronic disease, decreased macrophage release of iron. So choice B, wrong fucking answer. Choice C, impaired heme synthesis, wrong fucking answer. Could do 45-minute discussion, okay? Lots of things such as lead poisoning, right? Inhibits ferrochelatase as well as delta ALA dehydratase. Could refer to sideroblastic anemia, delta ALA synthase inhibition, either X-linked recessive or due to something like alcohol. Acute intermittent porphyria, okay? Deficiency or impediment of porphobilinogen deaminase. Could be porphyria cutanea tarda, so uroporphyrinogen decarboxylase deficiency. Choice C, wrong fucking answer. Choice D, Increased macrophage release of iron, wrong fucking answer. As I just inculcated, in anemia of chronic disease, we're going to have macrophages having a reduction of iron release. Okay, so once again, IL-6 will cause the liver to increase hepcidin. Hepcidin is going to cause decreased absorption of iron from the small bowel. The duodenum is where most iron is absorbed, as well as causing decreased release of iron from macrophages. Wrong fucking answer. Choice Z, mitochondrial iron accumulation, wrong fucking answer. This refers to sideroblastic anemia. So, as I just said a moment ago, first step of heme synthesis is going to be succinyl-CoA plus glycine via delta aminolevulinic acid synthase, and vitamin B6 goes to delta ALA. So if that step is impeded, either XR or due to some condition or something like alcohol, we're going to get what are referred to as ringed sideroblasts, where you have mitochondria within primitive RBCs that remain iron-laden. Okay, so iron cannot be released from mitochondria. So we have iron-laden mitochondria that encircle the nucleus, and these stain with Prussian blue, where they have characteristic blue dots, these ringed sideroblasts, and it's a spot diagnosis / slide you need to know for USMLE, which I'll link my heme PDF below. Choice E, wrong fucking answer. You know the deal. To make more content, if you like my stuff, subscribe my channel. And I appreciate your time. That's it.